Before we get started, I would like to share a few housekeeping announcements. All of the participants are on mute, so please submit your questions at any time through the chat box in the lower right-hand side of your screen. Please be sure to disable your webcam as it may affect the bandwidth for some participants. And also please be advised that we are recording the session so that the session as well as the presentation, and these will both be made available on the Summit YouTube channel following today's session. I would like to remind everyone that this discussion will continue after the webinar on the Springboard as well as the CI network. My name is Elizabeth Sorlamichos, and I am the moderator for today's webinar. Our panelists for this discussion include our two presenters from Tuesday, Catherine Bertram and Ketan Chitnis. Thank you again, Catherine and Ketan, for joining us. We also have Dr. Susan Goldstein, who is joining us as well as one of the panelists. Catherine has been providing SBC and advocacy support to public health emergencies, malaria, child survival, and nutrition programs for the last 9 years. She provided technical SBC support to teams in Liberia, Guinea, and Sierra Leone during the Ebola outbreak in West Africa, conducting exploratory missions and contributing to the SBC assessments and recommendations. She provided technical SBC expertise and capacity building support to UNICEF C4D in Sierra Leone, serving in the social mobilization pillar and developing standard operating procedures for integrating social mobilization throughout the emergency response. Catherine also led the development of an emergency risk communication implementation kit, also known as an iKit, and the Ebola communication iKit under the USAID-funded Health Communication Capacity Collaborative. Catherine is currently working on the OFDA-funded READY initiative and is coming to us from the Center for Communication Programs. Ketan is currently the Chief of Communication for Development, C4D, at UNICEF in Mozambique, where he manages UNICEF's work across social and behavior change communication in health, nutrition, WASH, child and social protection, as well as external communication and public advocacy for children's rights. Previously, he had worked on providing global and in-country support to risk communication and community engagement, also known as RCCE, across several public health outbreaks such as H5N1 and H1N1, Ebola, Zika, and cholera, and is now engaged in the COVID-19 response in Mozambique. His specialization is in public health communication and community empowerment in primary health care, and he holds a doctoral degree from Ohio University in this field. As I mentioned, we are also joined today by Dr. Susan Goldstein. Sue is currently working as the Deputy Director at the South African Medical Research Council Center for Health Economics and Decision Science, also known as Priceless. She is medically qualified and specialized in community medicine at the University of Witwatersrand and has 22 years of experience in public health, in particular health communication and health promotion. Sue previously worked with the Soul City Institute, where she developed television, radio, print, and social mobilization interventions for adults and children. She also has vast experience in communication around HIV and AIDS, having worked with the Beyond Awareness campaign and the Komanani campaign. She's also worked in communicating with children through the development of the Soul Buddies vehicle under the Soul City Institute. Sue lectures at the University of Witwatersrand School of Public Health and teaches at the University of KwaZulu-Natal. Sue is also a member of the 2020 SBCC Summit Secretariat. We are so glad that you all have been able to join us, and we're looking forward to discussing the questions that you submitted and you shared during Tuesday's webinar. For today's webinar, we will focus on a few different themes that came out of the questions that you all submitted. If you have any additional questions or any additional comments as the discussion is underway, please feel free to engage with us by adding your comments and questions in the chat box at any time along the way. In addition to the webinars that we're organizing this week, these discussions are being held on both Springboard and the CI network. A moderated discussion will be held next week on Springboard, and we encourage you to register so that we can continue these conversations. Lastly, before we get started, we want to emphasize that this is an agenda that is evolving rapidly. By organizing these webinars, we hope to start conversations around SBCC in the COVID-19 context. Right now, we have the ability to share and discuss what we do know and what we're thinking about, but we also know that what we're thinking about today may change tomorrow. So with that, we'll get started with our first thematic discussion. The first theme that emerged out of the webinar on Tuesday was around coordination for better harmonization. And I just wanted to take a moment at the beginning to mention to everyone about the global coordinating mechanisms for risk communication and community engagement that do presently exist. WHO has the GORN network, which is the Global Outreach Alert and Response Network. And this is one of the primary coordinating bodies, which has weekly calls. And from that GORN network, we're able to make sure that people who are working in the global leadership area of this response are able to make sure their information is all coordinated. There is also the core group, which has emerged as another one of the global coordinating bodies. But I really wanted to also take the moment to emphasize on the importance of coordination at country level. And for those who may not have had an opportunity to work in an emergency response setting previously, it seemed valuable to explain a little bit about how coordination tends to work at country level. And my own experience in the Ebola response in West Africa is that much of this coordination is directed from the WHO structure, which means that at country level, there would be something like an emergency operations center or an incident management system or something like that. And that could be under the Prime Minister's office or under the Ministry of Health. From that, there would be a risk communication and community engagement technical working group or committee of some sort. For those who worked under Ebola, this was what we called the social mobilization pillar. And it's critically important that anybody working at country level in the COVID-19 response coordinates their efforts through that risk communication and community engagement structure within the country. Similarly, at local level, there may be other coordinating bodies, and I just wanted to emphasize how important it is for everybody to make sure that they are tapped into what other people are doing to make sure that gaps are filled and information is not contradictory or overly replicated. And I think one of the important aspects of doing this is because we are getting technical guidance updated regularly as the science tries to help us understand more about COVID-19. And we had several questions that were specific technical questions, such as, what about the use of masks? What is the protocol for contacts after quarantine if the person they had contacts with is over? I'm seeing notes that some people are not finding it audible, but others can hear. So I hope those who are not finding this audible will be able to adjust their settings. So I just wanted to kind of round it out by saying some of these technical guidance questions that we got in the chat box were ones that we really aren't able to answer at this point, but the information will come to us through the global coordination structures, and that is how that technical guidance gets agreed upon and then shared and disseminated. So that's underscoring the importance of being tapped into the coordination structures to make sure that we are sharing correct and up-to-date information as much as possible. So I'll pause for a moment and invite any of our panelists who might like to add something to that overall framing about coordination.
Hi, it's Sue here. I think it's really important at a national and at different lower levels to think about trying not to duplicate work and waste time, and also working together with the EOC. So sometimes the EOCs are very technically oriented, and they are very medically or biomedically oriented. So one has to sometimes force one's way into the communication environment. But I think it's still critical that we all have similar, at least know what is going on and at exactly the same time, and are able to then know which sources of information are the most important.
Thanks for adding that, Sue. Agreed. Keaton or Catherine, anything else to contribute? Otherwise, I think we can move on with the next set of questions. And as I mentioned, we did collect all the questions that had come in and collected them in sort of different thematic areas. So the next thematic area is around messaging and content. And again, sort of tying that back into the importance of national level coordination for any national messaging. But one of the sets of questions was around fear-based messaging. How does one change the behavior of communicators who are putting out the messages of fear? And how do we ensure that people understand the gravity of the situation without a fear-based messaging approach? Fear-based messaging typically leads to stigma and misinformation, especially in low resource settings where formal literacy is low and access to information and services are limited. Catherine, perhaps you'd like to start with a response to that?
Yeah, hi, thanks so much. And Lindsay, if you can go back to the previous slide, please. Great. So we talked a little bit about this yesterday, but to address sort of those issues of fear and addressing non-compliance or complacency without stoking fear, I just want to go back to this extended parallel process model. And emphasize how important it is that people really need that accurate, concise, clear information with those simple, doable actions that they can perform to reduce risk. And so we can turn to this model again to really emphasize the importance of that balance between providing that clear fact-based information that also looks at the severity of the disease and the susceptibility of that disease, and balancing that out with self-efficacy, so that we're providing that information so that people feel more confident to act and believe that their actions are effective. So again, when we have that balance, people tend to then control the danger rather than controlling their fear. If their perception of the threat is really high, but their perceived efficacy is low. And as well, if their perception of threat is too low, where they're not really even paying attention to those messages at all. And so people really need to gain that sense of control, and they need something to do for themselves and their families and communities, and that will help them gain that sense of control. And I may just jump ahead a bit here because there was another question similar to this around sort of complacency, and I think around social distancing. And so while the effectiveness of this approach may depend in part on the context, for example, how socially minded people are in different contexts, we can use social responsibility messages to encourage people to not only comply to protect themselves, And in some cases, people can tend to be overly optimistic about their ability to control their own risks, or may not be overly concerned about their risk of severity of disease, but that they can have a responsibility to protect others, whether that's other people in their family, in their community, and in the nation. I'll stop there and I'll ask if the other panelists have anything that they would like to add.
Keaton, Sue, anything you want to add?
I feel a bit of a fraud because I haven't been involved in a pandemic before, but I really feel that the asset-based approach is a really valuable one in terms of dealing with contexts with which a lot of other people are not familiar. So in poorer areas, just looking at what happens in slums, in what we call informal settlements in South Africa, or even in small houses, tiny houses, it's a terribly different situation to middle class and Europe, etc. And I think the context makes it difficult for recommendations, but if you look for asset-based approaches, so if you look and see how are people doing it, how are they doing it well, within that context, that can be an incredibly positive message and engagement with people, and takes away a lot of that fear that, okay, somebody like me can do it.
Thanks for that, Sue. I think, yeah, that's really emphasizing on that efficacy part and the person feeling empowered to do the action that is required of them. Keaton, anything you'd like to add?
No, not at this point. Thanks.
Okay.
Maybe just highlight and emphasize that point, because I think it's a really excellent one. And that links back to some of the theoretical models that we were talking about yesterday as well. You know, making sure that people can actually, you know, observe how to actually practice these behaviors, and the fact that they can also see that those behaviors are effective, and engaging other influentials to help sort of promote those behaviors as well. And importantly, you know, they can see, you know, how simple it is and how, you know, feasible and doable it is for them to practice.
Yeah, somebody in the chat box had added that small doable actions approach, and again, emphasizing on the doable and what makes it manageable. Yeah. And another category that we had discussed, seen a lot of questions about actually was around trust as well. And I think fear and trust sort of go hand in hand. So the questions are things like, why is trust important in SBCC and in risk communication and community engagement in particular? And how do we know who the audience trusts, and how can we build and maintain trust? And we didn't really touch on trust that much in the first webinar. So Keaton, I wonder if maybe you could take on a couple of those questions.
Sure, thanks, Elizabeth. Hope everybody can hear me. Indeed, I think, Lindsay, if you can go to the next slide, please. Indeed, I think there are several examples and models of building trust. And as we know, particularly in the issue of the area of both crisis and emergency risk communication. So this is an example from CDC, for instance, but also several other guidance documents that we use are particularly looking at giving recommendations in terms of being able to be accurate, timely, you know, be first, provide the right information, go back if the information changes and recommendations change, because it's an evolving epidemic or a pandemic, and science is not fully you know, available in terms of recommendations. So essentially, it's all about providing all these tools for us to have as you know, the spokespeople speak about it to the population, as the media speaks about it to the public, including, I think, those who are probably the ones which are marginalized and more vulnerable and have some pre-existing challenges with regards to trusting certain sources of information. So this is one of the examples of building trust. The other issue is also with regards to who is giving the message. So it's essentially the messenger is as important as what we are talking about in terms of preventive actions to mitigate the risk of the pandemic. And here, there are two components to it. One of them is related to essentially building trust by using a combination of competence and kind of affective dimensions. So you need to have correct information, right kind of scientific information, trusted sources, all of that. But at the same time, it needs to also, in some ways, ring a bell to people's hearts. So that's where I think then the information and the messages and the communication becomes more real, more tangible, and people are able to act on it. So some simple ways in which this is done for several public health issues, including now for COVID-19, is beyond relying on official spokespeople, beyond WHO and other agencies and the government spokespeople, also calling upon local celebrities, local kind of trusted people within the community when we're looking at community-based kind of activities with leaders and religious leaders and so on. And that's essentially what we are seeing through a range of communication approaches and spots and messages that we are seeing. And this essentially in many ways kind of brings a bell towards addressing this heart and mind issue and contributes towards building trust. Next slide, Lindsay, if I may. Because there's another element to trust, and which is really about having more of a two-way communication, right? So it's about something which begins before a pandemic, but also during a pandemic. One can start rapidly working on these kind of a three-step approach, but it's mostly at a more local community level. How do we look at providing information, education, communication, and engagement approaches, at the same time using the kind of opportunity to build a relationship with communities. And then during an emergency, it becomes a little bit easier because there's been a relationship, with the communicators, with the community engagement officials, with the media, with the spokespeople, and so on. And it's also the other element with regards to building resilience, because people are trusting what and they know what they can do. Goes back to issues around efficacy, both self and collective efficacy, and ways in which communities can prepare and prevent the disease for themselves, as well as I think their immediate neighbors and communities. So maybe Elizabeth, I'll stop there if somebody wants to add.
Great, thanks, Ketan. Sue or Catherine, anything you wanted to add about trust?
I mean, I think most of it has been said already really nicely. Maybe just one other point to make is just the importance of really, and I think this is coming out in the chat as well, really being that active listener and respecting the voices of the community. I think there tends to be sometimes dismissive attitudes, even by organizations and response agencies, in terms of what the community knows and their concerns. And to build trust with them is a two-way process. And so we need to also trust them so that they can trust us. And making sure that we're hearing their concerns and addressing those concerns in a timely fashion as best we can.
Yeah, thanks, Catherine. One of the other things that came up in the chat box just now that I wanted to touch upon was also the importance of that, remembering the gender and diversity lens, and that it obviously is critical, but it's a reminder of our preparedness work. And the preparedness work is all the things we've done before the outbreak happens, which includes things like understanding more about how gender plays a role, and how to be sure that we have appropriate diversity in our messages and messengers. And the more we can do before an outbreak happens, the better prepared we are. So that's when the outbreak happens, we can rely on, the literature and the research that social scientists had already done around many of those things. Obviously, at the moment, we're in an outbreak, so we can't go out and do that much, sort of formative research and groundbreaking things along those lines. But Sue's going to talk a little bit more about research in a moment, but I did think it's important to remember that sometimes we have those resources already available to us. We had one more sort of thematic area around information in general. One of the people in the put a comment in the chat box about Caton's first slide, and that first step of being first is very difficult in the era of social media. And certainly this outbreak, we are seeing what has been dubbed the infodemic, and just the mass amount of information that's out there, including a lot of rumors, a lot of misinformation, and perhaps some of that is derived as incorrect information coming out of something science has said. So a couple of questions along those lines. What are SBCC implementers doing to address the infodemic of information and misinformation in the populations that they serve? Sue, do you want to start us on that one?
Yeah, so I think in many countries, I don't know if all, there are groups of communicators who are trying to monitor myths and incorrect information, and then putting out the correct information. It's not easy because there is an extreme amount of communication going on. What we are trying to do in South Africa is encourage people to only use specific sources of information, the more official sources. So what's happening, people are gathering the information from blogs, from all sorts of things. And one good example at the moment is that there is a huge debate about the use of masks. And I know that there's an international debate about it as well. But in South Africa, the debate is slightly different because we don't have personal protective equipment for frontline health workers. So the message that is very clear coming from WHO is about who should wear masks. It's very clear, but there's a constant kind of questioning and discussion. And we're trying to say, let's try and keep people focusing on existing and trusted in areas of places to get information from. I think the other thing that does make this whole thing very difficult is, last night I was on a chat show, a questions and answer show with an incredibly smart virologist, and he was answering questions, and I'm a doctor and I couldn't understand half of what he was saying. Not exactly, but I think if you don't understand something, you can infer all sorts of things from the communication. So I think that's another point, is trying to get communication in very plain, clear language, as Catherine has mentioned before.
Thanks, Sue. That's a great example. Catherine, do you want to add something more on the issue of rumors, misinformation, and the infodemic?
Sure. I think a lot of this was touched on already, but I think, as was said, there are some organizations, the risk communication, community engagement, coordination mechanisms that are set up in different regions and countries that are coordinating the tracking and addressing of rumors, misinformation, and disinformation across partners and even government agencies. And so making sure that we can connect with those coordination mechanisms, with those partners to harmonize our messages, to make sure that the data that we're getting around some of those rumors are being fed up to those other coordination bodies. And maybe just another example, and I don't know if anyone from IFRC is on this call, but I know that they're supporting a lot of this work in a lot of regions and countries. And specifically, they're supporting their own national societies to, you know, collect and use and act on the community feedback systems that they've developed. And they produce these weekly fact sheets that address most of these commonly asked questions and those rumors and fears from communities all across Africa, for example. And one of the things that they've started doing is producing these weekly videos with health experts, addressing a lot of the relevant questions from the community members and providing those needed facts. And so, you know, they share these videos on different technology or in social media platforms, for example. I know other programs are using other tools, you know, Viamo, YouReport, WhatsApp, to collect some of these rumors and misinformation and social media tracking, for example, and Sue was already talking about that. And maybe I'll just say lastly, Johns Hopkins Center for Communication Programs developed a guidance note on tracking and addressing rumors, and I'll include the link on that in the chat box.
Thanks for that, Catherine. And I think this is sort of along the lines of what we've been talking about anyhow. So how do we complement faith-based beliefs with factual scientific data without maligning the contextual needs, histories, and perceptions? For example, you know, COVID-19 won't happen to us because, you know, we have some kind of other protection and we're already engaging in safe behaviors, etc. Keaton, maybe you want to take that one.
Thanks, Elizabeth. I'll start and maybe somebody else can jump in. I mean, again, we're relying back on decades of work being done with faith-based organizations and groups, whereby, you know, from immunization to disease outbreaks and so on, like Ebola and Zika and so on. So I think it's the same principle. The idea really is about figuring out, you know, working through the guides and the trainings that happen with faith-based groups with regards to the science of the disease and what is are the recommendations with regards to preventive actions and mitigating the impact, and then you know, using those to be made part of their you know, their sermons and prayers at the weekly level, at the community level. So that's one way in which it's been done, and it's also about essentially identifying local leaders, and religious leaders are key in terms of building that trust and engaging with communities. It does pose some issues, I guess, in terms of also working with faith-based groups, particularly when we're looking at the fact that mass congregations are more or less cancelled, probably in all countries. And I think that's then also pushing us to think of different ways of delivering or you know, reaching to their congregations through maybe remote means, technology. You know, I mean, simple means like loudspeakers are being proposed, but there's also, I think, pre-recorded prayers that circulate via, again, those who have kind of WhatsApp and other kind of SMS-based tools. And then just finding ways to still engage with the population that trusts the religious leaders, you know, using different channels. So those are, I think, kind of two sides of the same coin with regards to how we need to work with faith-based groups for this pandemic. Over.
Thanks, Keaton. And Catherine, any additions to that?
No, I think that summed it up. Thank you.
Okay.
I think it's Sue here. Can I just add, I absolutely agree. I think in sub-Saharan Africa, we also have a lot of experience, and we can build on working with faith-based organizations through the HIV epidemic. And many people who've done that will agree that it's actually going to be a lot easier than talking about sex. So I think we could really use our contacts and engagements that we have been ongoing for the past decade or 2 decades even to build on that. The other point I just wanted to make, and I think Ketan's absolutely right, that because of the social distancing, huge big events, Easter, Ramadan, all sorts of events are going to have to be cancelled. Pesach, I think every Jewish or many religions are going to have to cancel their celebrations. And what's on our side is that the religious leaders are going to be looking at ways to reach out to their communities. So I think that's great, because we can then just tap in, but we can tap into the leaders and assist and work with them to tap into their communities.
Yeah, great. Thanks for that, Sue. And that is a reminder again of, building on the resources and relationships and tools and things that had been developed prior to the outbreak, and that we don't need to think we're starting from zero. Lots of these networks already exist. And obviously, when we're working in a situation where people aren't gathering face to face, it's much easier to work within the networks of people that you already know. I'm going to shift gears now a little bit, and we've talked a lot about messaging and messages and information in general, but what is the base of that? And that leads us to the clustering of questions around research, and particularly formative research. So some of those questions included things like, is it necessary at all to gather field information on the situation before coming up with an intervention? And if yes, how do you do this in the context of an emergency? And what suggestions do our panelists have for ways to undertake formative research in a context where face-to-face or focus group discussions are not possible? Sue, perhaps you can get us started on that, including some of that information from Geopol.
Yeah, thank you. So I think the answer is absolutely, we have to do some research. I think the point is that, and remembering we are talking a lot about messaging, but we really should be thinking more about engaging and thinking a lot about the context in which we are sending these messages, if you like. And having social distancing really does mean sending messages, which we have as a community found to be not as effective as a two-way communication. So there are lots of ways of collecting information, not very easy, and I think will require a lot of out-of-the-box thinking. One of the things that this organization, the Geopol, do is that they have SMS polls around the world, and they've been asking people to respond to questions. I don't know what their sample is, but they've got samples from various countries in sub-Saharan Africa. So I thought that it might be worth just sharing a little bit of it, and we can also share the link to their sub-Saharan African survey in the chat box. I think one of the things is that they found is that, in fact, many people are very concerned about coronavirus. And the levels out of 5 were 4.4 for South Africa, 4.3 for Kenya, and 4.2 for Nigeria. I think the other thing is people were very aware that public places are a problem, public transport are a problem, and people, yeah.
Sorry, Sue. Yeah, go ahead.
Oh, okay. Sorry, I thought somebody was asking me something. Okay, so I think that it's very useful to have this kind of information, just to give us a kind of background. How many people, what percentage of people are sharing or getting the information from WhatsApp and so on. But one thing that has concerned me and worried me a lot about these electronic databases is that it may reflect, and I don't know because I don't know the sample, but it can sometimes reflect the middle classes and does not reflect the reality of people who are too poor to have data or don't have access to the internet or whatever the issue may be. So I think one has to keep remembering that whenever we find solutions to formative research. I think the second thing that I wanted to talk about is about creativity. And it was just illustrated for me now. I got a WhatsApp saying somebody had used a young girls group, WhatsApp group, to start sharing information. And just by providing this group of young girls, they worked together for some other reason, with data, enabled them to start engaging and to start talking about it, and then becoming sentinel sites, if you will, or leaders or people who can pick up information from communities and distribute, and vice versa. So it becomes a sort of network of small WhatsApp groups of people based in communities. But the key point here is that it does mean providing data, and particularly in South Africa. I think the last point I want to make is that we can, in this kind of pandemic, we can really push service providers off, particularly phones, internet service providers, to help with reaching groups of people and engaging. And I think that there is one in South Africa who did eventually sort of send out one message. But I think as a country and as organizations, we can really push them to do more, to collect data and to collect information and to give messaging to existing groups. So one of them, if people know, in South Africa, there's a cell phone group network called Mom Connect, which is for women who are pregnant and just had babies. And it has, I don't know, around 900,000 contacts, and certainly could be used. But the Department of Health said they couldn't use it because it was too expensive. So I think there are things like that that can really be pushed and advocated for, which can really reach out fingers into communities to hear as well as to tell. I think I'll stop there.
Thanks, Sue. In the interest of time, I'm thinking maybe we'll move on to our next category of questioning, which really was around that reality of physical distancing in different contexts. And there are many different angles to these questions. So let me just jump right in. The first question was, has WHO updated the guidance to shift from social distancing to physical distancing so that people are more clear about what the ask is, and that focus more on social connectedness while maintaining physical distance? Maybe I can just quickly respond to that one to say that we are seeing this as a welcome switch to make sure that that is more clear where the emphasis should be. But that has not necessarily come out clearly in all the guidance documents up to this point. So we are still hearing some interchange between those terms, social distancing and physical distancing. But I do hope that as we move forward, we'll see a little bit more emphasis on physical distancing while maintaining social connectedness. But Catherine, I'm wondering if you could answer this question. Do you have any recommendations on cases where physical distancing leads to exclusion instead of collective grassroots action?
Yeah, thanks so much for that question. And if I understand it correctly, I think although, it's more challenging, I think it's still possible to, conduct two-way communication and participatory engagement with these physical distancing measures, using some of these other alternative ways of communicating that we've been talking about, those mobile or technology platforms, or those, interactive community call-in radio programs, for example. We talked about WhatsApp groups and other channels. And I might suggest as well partnering with other organizations that have networks with groups that appear to be excluded, and then expand reach to them. So for example, a national level mapping of NGOs and their networks, or a mapping of national or local level special interest groups can be conducted. It can be done, through an email survey, for example, and then leverage those communication channels that people are already using and trusted influencers to reach and engage them. And I don't know if anyone else on the panel would like to add anything to that.
Otherwise, I'm thinking maybe we can just move on with the questions, since there are quite a number in this section. And the next one I'm going to direct to Keaton. So if he had something to add on the other one, that would be great. The next question is, how can we most effectively shape behavior so that people comply with physical distancing and shelter-in-place policies? When government directives have tended towards direct orders, are there more effective ways to achieve voluntary compliance? Keaton?
Yeah, thanks. I was on mute. Well, it's a great question. And I think there are some examples of this. And one of them is essentially tapping into kind of existing behaviors that people are already practicing with regards to social responsibility. So when it comes to recycling, or when it comes to neighborhood watch, or any other kind of such examples, kind of triggering those practices back right now in the context of this emergency. So getting more voluntary compliance, and making sure that people are understanding why this needs to be done, rather than having to be enforced using police or other forms of kind of more aggressive ways. It also there's ways of kind of using more peer pressure over here, or kind of peer-based support that can be provided, again in terms of more approaches which are allowing communities to come together, helping each other out. It's in some of the guidances at the community action level, what should be done. So the support can be provided to the elderly, for instance, or those with having households with people with disabilities or children with disabilities, how the community members can come together and help them, allowing essentially a sense of still having some community while practicing, of course, safe distancing practices. So I think those are certain examples in which there has been attempts made to look at, again, community actions that can provide ways in which these behaviors can be adopted. And lastly, I think, as I said yesterday, there has been, I think, again, some evidence in the past about teachable moments and short-term behavior change, as opposed to kind of practicing something as a habit. We know developing habits is more difficult, such as going to the gym or quitting smoking and so on and so forth, as opposed to practicing short-term habits. So again, if the social distancing measures are, especially for a shorter period of time, a few weeks, that can also be used as a trigger while communicating that the behavior change is essentially for a short term to prevent individuals as well as communities. I'll stop here, Elizabeth.
Great, thanks. Was there somebody else?
Maybe Sue or Catherine wants to ask.
Yeah, no, I think that there was somebody who was having a microphone issue outside of the panel. Go ahead.
Hi, okay, sorry, Elizabeth, I'm supposed to let you know before. I think that what's interesting in our context, and it may be in many countries, is with a national shutdown, or lockdown as they call it, and the government bringing in the army and the police. So behavior is being externally controlled, sometimes in not human rights way. And I think that it becomes even more complex because we're asking people to behave in a certain way, but we're also being quite punitive. And so it's quite difficult to engage with these habits and so on. And what worries me around the lockdown is that I think people think that it's going to end at the end of the 21 days of lockdown, and then we'll be able to go back to exactly what we were before. And in a way, that's when our SBCC work needs to start, is to get people to start behaving in safer ways. So it's complicated in many places in different ways.
Yes, it absolutely is. And I think it is going to be an enormous challenge for us to get people to maintain safer behaviors if there isn't, as we transition out of whatever lockdown situation people are in. In terms of thinking more about how to continue engaging with communities, there's another question here, or two questions that sort of cluster together. In sub-Saharan Africa, the majority of people are illiterate and do not have sufficient ICT gadgets, such as radios and mobile phones. They rely on interpersonal communication support provided by health workers. In the face of physical distancing and working from home modalities, how can these communities be supported to access timely and correct information on COVID-19? And then a similar question was, in a highly contagious context and in African country settings where mass media, including social media and mobile network coverage, may be low or non-existent, what are your recommendations and suggestions, knowing that community engagement interventions might be constrained or not advised? Catherine, maybe you want to take a first response on that.
Sure. And then I'd like to turn it over to Keaton as well. But just to say that people are highly adaptive. And so I might suggest finding out, and I touched on this the other day, how people are still communicating and getting health information, and who the influencers are in their community and how they're already adapting to social distancing measures. And then consider the benefits of leveraging some of those channels. Some ideas have already been, as I've been kind of scrolling through the chat, some ideas around this have already been coming up, which is great. So then consider some of those approaches, like using the loudspeakers, as was mentioned before already. For example, some of those religious leaders engaged to use loudspeakers to promote protective measures during Friday prayer calls. Importantly, we need to ensure that that type of information is that's being disseminated is accurate. But maybe I also want to mention here as well that some organizations, such as the national societies, are still conducting door-to-door social mobilization, but using strict safety protocols. So the core group, Global Health Security Project, for example, is developing they have these draft guidelines now on COVID-19 house-to-house community outreach. So, within there, it would stress the importance of ensuring that staff and volunteers are provided the items that they need to stay safe, that there's a step-by-step process that includes understanding permissions and conducting a risk mitigation assessment, complying with those social distancing protocols. That said, we need to make sure that we are doing no harm to beneficiaries and to those staff and volunteers. I don't know if anyone would like to add anything from the panel.
Yeah, and I'm just actually observing time that we are probably going to have to wrap up very soon. So Keaton, maybe you can take this as an opportunity to give any of the remaining remarks you wanted to make.
Sure, I think Catherine touched upon most of the points, but just from what we are doing also in Mozambique, and I've seen in some other countries, addition to volunteers, like through the Red Cross societies, we're also looking at community health workers, training them using some technology-based solutions, and then providing protocols and PPEs to go out and continue to still do some outreach activities. Also kind of jumping ahead to questions, and they're in the media as well, with regards to engaging the community in this response as much as we should, despite having these challenges, because there was plenty of lessons again from Ebola that there was a big problem when it was a very top-down approach. So there are this guidance, and I think some examples in countries of using kind of trained community volunteer groups, which are enforcing their own measures of protecting their neighborhoods, broader communities, while maintaining physical distancing, using some of those examples that we talked about day before yesterday in terms of, marking spots and so on, so that people know that they're supposed to stand apart, hand hygiene as much as possible and so on. So I think the role of the community still remains. We have to be, I think Sue mentioned the word a bit creative, like in research, we'll have to be also a bit creative in doing this distant community engagement work. But it cannot be just left to essentially government-led responses, which may actually be a little bit more, not inclusive of rights of communities. Over.
Thanks, Keaton. And Sue, I'm wondering if you have any last reflections that you'd like to share with the group?
Yeah, I would. One thing that I've noticed about this pandemic is that we haven't been turning our language around, and I still strongly believe that focusing on positives, trying to get that balance between the fear and ability. But if you think of it, even in the worst case scenario, 85% of people get better with no problems at all. And that's a lot. And if you can try and think of speaking to people about some of the positives, I know I sound a little bit like Pollyanna, but there's a decrease in traffic accidents when there's lockdown. There's decreased alcohol-related trauma. And so on. The only one that worries everybody a lot is the increase in gender-based violence or domestic violence. But I think in general that there are positives. There are important things that people are starting to talk about, think about, discuss, the value of health workers in our society, how we undervaluing community health workers in particular, looking at the terrible living conditions that people live in and saying, oh, we better do something about that because they can't endure a lockdown. I think there are a lot of things that we can engage with and start conversations around, which perhaps we can try and look at on the positive side and bring positive social change.
Thank you for that, Sue. And I'm really happy that we can end the conversation on the positive note and the positive side, because agreed, there are good things to come out of this crisis. I'm sorry that we've run out of time, because there really were so many interesting questions and so much discussion happening in the chat box. And I wish we had another hour or another day to continue our conversation. But I would like to thank our panelists again, Catherine, Keaton, and Sue. Really appreciated all your insights. And I am just being reminded that, in fact, we do have 15 more minutes, which is fantastic. So sorry about that. I will not quickly wrap us up, but instead I will go back to a couple of the questions. And remembering now, thinking about the community engagement side of things, Keaton, there was another question for you around the contextualized local systems for information dissemination and community engagement, and how they can be developed in places where mass media and social media are unreliable. The specific question was around rural villages in Pakistan, but I think that really does apply for so many places. And I'm wondering, Keaton, if you have some thoughts on that.
Well, I think we touched upon it, but Lindsay, maybe you can put the slide on physical distancing. Yeah, I mean, it doesn't necessarily capture a rural setting per se, but I mean, one of the things that's happening is really some of the new behaviors like keeping a distance, in places usually where people are crowded and people are not used to keeping distance for a range of reasons, including cultural reasons, I think is to visualize, and contextualize that based on local context. We are seeing quite a few of these examples, particularly these circles and squares and lines and tapes across countries, and it's also being used particularly where when it's a situation of these lockdowns and when essential services are open. Those then shouldn't become places where people potentially infect somebody else or are at risk of getting infected. And for instance, in banks, in grocery shops, in medical shops, all of these areas, these examples are being used with regards to social distancing and then in that sense, or physical distancing, and in that sense, communicating further with regards to other practices. Also, when it comes to, I think, aspects related to to isolation. Those are the questions, and quarantine. Again, what's being used in some contexts is through trusted kind of outreach workers, training at a local level, what it means for somebody in the household who's showing symptoms to be quarantined, and then somebody who's actually sick to be isolated. By providing, I think, again, practical kind of training tips, and that's been done whether it's again in an urban context or a rural context. And I think lastly, it's probably for us more difficult, as there's been some, I think, literature out around doing physical distancing is more of a challenge in urban context, particularly in kind of densely populated settlement areas or slum areas, as they're called in some countries, where I think it's a little bit easier to do things in rural areas where you can have more space. You can also bring markets closer to communities and so on. So I think those are just some of the examples. Over.
Thanks for that, Ketan, and some great slides. I think probably everybody's been seeing some examples of these in their own environment. Sue, there's a question for you about what can we do at the field level to make people aware about COVID-19 without the access to them, but maybe the more relevant question to you is, how can we evaluate the success of this?
That's a very interesting question. I think that we can do a number of things. And I think what's important is not just focusing on reaching people, but trying to understand whether people have actually changed what they do. What I've noticed with the Geo poll, and there's another poll that's going around in South Africa, but I think it's also middle class, is their rounds. So they're actually doing longitudinal studies, looking at waves of people, how they're changing their behavior. And I think that we could do that quite easily if we manage to access groups of people through WhatsApp groups or through community health workers. We have got a plan to do testing and treating and isolating through 10,000 community health workers in South Africa. So, I mean, if we're smart, we can use those in a way to also gather information around how people are changing and what is happening. But I guess in the end, history will tell us if we were effective or not.
Thanks, Ketan or Catherine. Any contributions on thinking about how we evaluate our success?
I think just to add a few thoughts, and I'm sure the group will have other ideas, but I mean, one of the things that we've been discussing is for some measures that we're promoting, I think visuals might be a way to capture, because it is at least distancing is a very visual behavior. And that might be a way to also use as a nudge to go back where things are not happening. But then, of course, relying back on some of the hand washing literature in terms of looking at some of the hygiene practices to try and see whether there were was enough of those behaviors. And we're also using more kind of traditional methods where, again, where people have access to phones, for instance, the U-report system in UNICEF, which can be a polling system, but also a SMS-based polling system, but we're also using it to identify kind of formative needs of communities, mostly adolescents and young people, and then providing that information and then over time polling to see if there's been changes with regards to at least some of the knowledge issues, some of the intention to practice, and the ability to practice some of the recommended behaviors. So yeah, some more traditional means have been used, but I agree with Sue. History will tell how things went.
Thanks. We have one last kind of cluster of questions around physical distancing, and how do we leverage community health workers to ensure continuity of care in pre, during, and after the outbreak? And I think that care is referred to all the other health care that people are still requiring in their normal lives outside of the COVID-19 crisis. And then, yeah, let me see if our panelists have some response to that question first about how community health workers can continue to provide care in the context of the emergency.
So I think this is a very difficult question, because if you talk to people, everybody's focused on COVID-19, and essential services like chronic care, like immunization, seem to be falling by the wayside. So I think this is a very critical area. What it's also highlighted, it's been going on for a while, but in South Africa, the value of community health workers suddenly are seen as so valuable, but they are paid a pittance, are not well integrated into the health service, and don't feel respected within the health service. So I think that has to shift if we're wanting to really get great service from the community health workers, although many are working under very difficult conditions and willingly. So I think it's also highlighted something that's really important, that community health workers should be the backbone of the health service and valued as such. But I think another point, and the trade union for health workers in South Africa are very adamant, is that you have to have personal protective equipment for these people going out into communities. You can't make people do work that's very, very dangerous.
Yeah, that is a very great challenge for service delivery partners, for sure, working with those service providers. I have one last question for our. Yeah, Catherine, go ahead.
Sorry. So maybe just to add, there are, in a humanitarian emergencies, which, this is clearly affecting all aspects of our lives, and particularly in resource settings and in areas where there are humanitarian crises. There are cluster systems set up that work on specific technical areas like child protection, WASH, and so on. And so within those cluster systems, there are organizations who are working on addressing these types of issues to make sure that there is continuity of care. Excuse me. In addition, I've already started seeing some guidance being put out by UNAIDS, by PMI, by other donors and other global coordinating mechanisms and organizations that are already putting out guidance around how we can continue care within a COVID-19 environment. And so there are organizations like Save the Children had started developing a framework, an integrated framework that looks at how we can still continue to provide care and nutrition and wash and all these other important areas, reproductive, newborn, and child health, you know, given the context of COVID-19. Using some of the existing guidance from these technical working groups. And so just wanted to bring that up really quickly. Thank you.
Thank you, Catherine. I appreciated that addition. I think we are now nearing the end of our time. And I had one last question for any of our panelists who would like to make a comment on this last question, which is that social and behavior change communication needs research and behavior change in action, behavior change action in communication. But how can it be more efficient during an emergency response as people in so many countries are reluctant to change their behavior despite knowing about the deadly consequences? So I think that's really a question about how can we speed up all our processes and not skip steps even though it's an emergency situation.
Sue here. Well, I mean, my perspective, and I could be wrong, is that I think there are a huge number of people who have already changed their behavior. There's a lot of people who have started hand washing more rigorously, more often. I wish I could measure it, but we can't. But I think if one looks at it positively, I think that people do respond to emergencies quite rapidly. I think what's more difficult is sustaining it over a period of time.
Thanks, Sue. Catherine or Keaton?
No, I think I agree. I think there is, and especially as you know, this is being done from a very kind of these, you know, the media is all over the place, and then there's also very strict government actions slowly being taken in several countries. So there is a lot of information out there. Several people are practicing. I think they see the urgency of it. I think people are able to practice or are convinced to practice at least certain behaviors over others. And then the rest is, I think, through the kind of strategies that we talked about better engagement and building trust and so on. So, yeah, it's complex, but it's moving in that direction.
Catherine?
No, I don't have anything to add. Thank you.
Okay. We are at our time, so I do want to thank you all once again for joining the webinar, and a special thanks to Keaton, Catherine, and Sue. Just a reminder, the webinar was recorded and the recording will be posted on the SBCC Summit YouTube channel, as well as the Summit website and on Springboard. We certainly hope to continue these discussions and encourage everyone to engage in the forums on Springboard and the CI network. And there was a whole topic area around violence that we would love to be able to continue the discussion on Springboard and CI network about that. And additionally, we could ask you to post any requests for tools or additional guidance that you would find valuable. We can use that opportunity to network people to the tools and resources available and identify if there are gaps out there. That moderated discussion will be held on Springboard until Tuesday, April 7th. A live discussion Tuesday, April 7th from 9 a.m. to 10:30 a.m. That's Eastern Daylight Savings Time. And a link to register for that discussion will be added in the chat box. Thank you again to everyone who joined us, and we look forward to continuing to learn from each other and support each other through our conversations. If you have any questions for our presenters or other general questions about the summit, you can contact us at info@sbccsummit.org. I think that's up on the slides. And we look forward to learning from you through our continued discussions, and we hope to see you later this year in October at the 2020 International SBCC Summit. Thank you again.